Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Great. Thanks, Brian. It's so great to be back here at the HIV Echo and see a lot of familiar faces. And so what Brian asked me to do is just kind of give an update, what's kind of new in hepatitis B. And I have like 3 topics today, and I'm going to check in after the second topic because I have a little bit more information than you guys are used to having. And maybe I'll just come back and we'll talk about some of the newer treatments that are coming out for Hep B as a future topic. We'll check in on that. These are my disclosures, nothing relevant to our discussion today, but make sure you know about that. Appreciate funding from HRSA. The 3 things I wanted to go over is some new guidelines that came out from the American Gastroenterology Association, the AGA, around what to do with all these patients who are on immunosuppressive medications. You guys can't watch any kind of TV these days without seeing all these advertisements for new biologics. And so we're getting a lot of those patients in the liver clinic. And it was great to have these new guidelines that came out early this year. And I wanted to make sure you guys know about that. And then kind of a more general topic is just to kind of let you know that there's a subtle paradigm shift in terms of who would we want to treat for hepatitis B. So I'm going to go through all the various guidelines. And then if we have time, I wanted to talk about some of the exciting developments around this new class of medications for Hep B, the siRNAs. Before we dive in, just wanted to make sure everyone knows why this is relevant to taking care of patients with HIV. And part of that is that it's pretty common. So globally, there's 5 to 20% of people who are living with HIV also have chronic Hep B. And I think that's really owing to really common shared pathways for transmission. In my clinic, most of my patients have gotten hepatitis B through maternal child transmission, but there's still a number who have contracted it through blood exposures like injection drug use and sexual. And if you look around the world, it's not uniform where you see HIV, Hep B co-infection, in particular sub-Saharan Africa and parts of Southeast Asia have even higher rates. And the reason why it's important to know about HIV, Hep B co-infection is that having HIV can really worsen the natural history of the hepatitis B infection. So if you're an adult and you're HIV negative and you're exposed to hepatitis B, you have about a 90% chance of clearing it. But if you have HIV, that goes down considerably. Also, the viral load in a patient who's co-infected is much higher. So that means that they're a little bit more infectious as well. And the disease progression of the liver, so fibrosis, is accelerated just like we saw in the past with hepatitis C. The 4th bullet point there is just reminding me that there's a reduced response to HBV treatment. And this is a reminder that we really don't want to be using lamivudine monotherapy, primarily because the hepatitis B can become resistant very quickly. It's called the YMDD mutation. So if you're just giving lamivudine, like 50% of people will get resistance from their Hep B. And then we also see a little bit more reactivation of Hep B in co-infected patients. So what I wanted to do is start out with a case, kind of get you thinking about this topic of immunosuppression. So this is a 40-year-old gentleman who originally presented with 2 weeks of drenching night sweats and fatigue. He is subsequently diagnosed with stage 3 Hodgkin's lymphoma, and his oncologist would like to start him on nivolumab plus doxorubicin, vinblastine, and dacarbazine. So relevant history, he's a 2nd-generation Vietnamese American born in Southern California and has never been screened for hepatitis B. So my question to you all is, should this guy be screened? So if you want to think about this, okay, we got the poll. Okay. Answer A is no, because he thinks he was vaccinated as a child growing up in Southern California. Is it B? No, because he should start chemotherapy immediately given the advanced nature of disease. Or C, yes, because he will receive immunosuppressing therapy. So maybe we'll go through the why A and B are wrong. So we started doing routine vaccination in the 90s. So this guy's 40, and I think he kind of maybe was just a little bit born too early. We weren't doing routine vaccination back in 1985 when this guy was born. So it's probably unlikely that he got that routine vaccination as an infant. Maybe he got it as an adult. So then in terms of the timing with the chemotherapy, you can start antivirals at the same time as the chemotherapy. So that's a wrong answer. Okay, so let's continue to the next question. So he does get screened, as you all suggested, and you want to order three tests. You want to order the surface antigen, the surface antibody, and the core antibody. And he's positive for surface antigen and core antibody. His ALT is fine, it's 25. His HBV DNA is not that high, it's at 2,000. Aside from some mild anemia, he's otherwise doing pretty well. So, what do you think about this? Should he start on antiviral prophylaxis for his hepatitis B? And answer A, yes, because he'll be taking a regimen containing an anthracycline derivative, an immune checkpoint inhibitor. B, yes, because he has a high viral load on Hep B, or no, because there's a drug-drug interaction between both entecavir and tenofovir with his chemo regimen. All right, great. Looks like the majority of you guys picked A, which is the right answer. So in contrast to patients who are not immunosuppressed, we really don't look at the viral load. It's more the surface antigen, and I'll go over that in subsequent slides. So that's why B was wrong. Both entecavir and tenofovir are pretty clean, not a whole lot of drug-drug interactions, so don't really need to worry about that. Why do we worry about reactivation of hepatitis B? It's because patients who are surface antigen, they can get reactivation in like 50% of the cases. And particularly with the case we were talking about here, this is not like a garden variety reactivation, like, oh, ALT goes from 25 to 75. These people go to like 500, 600, their billy goes really high. They can go into fulminant liver failure. And, sadly, this happens almost every year somewhere in Washington. We've seen people die from it. We've seen people need liver transplants. So just want to make sure that everyone knows that this can be very serious. So it can also happen with isolated core antibody positives. Fortunately, not as common, but it does happen. And it really can be any kind of chemotherapy. But the greatest risk are with the anti-CD20 antibodies. So in the old days, patients who had lymphoma would get R-CHOP or rituximab with chemotherapy, and that was notorious for causing really, really severe reactivation, and the effect on the CD20 cells lasted for up to a year. So you had to prophylax those people for a long time. I just want to briefly center you on what the old guidelines were. They were a little bit simpler, but we basically, you break it down into surface antigen positive, isolated core antibody positive, and then negative for both. And then we would talk about very high risk or other treatment. And for the most part, people would either get a monitoring or antiviral treatment. But what has happened in the last 10 years, there's been a lot of new immunosuppressing medications. So it was time to update those. Things like checkpoint inhibitors, nivolumab is in the case today, was an example of a checkpoint inhibitor. CAR T therapy wasn't around, tyrosine kinase inhibitors, and also things we didn't really think about. So a lot of my patients who have liver cancer will get a procedure in IR called a transarterial chemoembolization, or TACE. And it seems like it's localized, but it does have some reactivation that can happen. And then also we saw this with hepatitis C treatment, that there were some people who would flare. So in general, what you're going to see with the subsequent slides is that there's a lower threshold for starting prophylaxis against hepatitis B. The way that the authors set this up is there's a series of questions, who should be screened, how do we risk stratify them, and based on high, medium, or low risk, and whether they should get prophylaxis or not. So the first question they asked is, for a person who has high risk of reactivation, should they get prophylaxis? And this is not any different. So these people who are surface antigen positive, getting chemotherapy, things like that, they should continue to do that. And it just assumes you're going to be able to use antivirals that have a high barrier resistance. That's the tenofovir analogs and entecavir, not lamivudine or emtricitabine. And you want to start that as soon as you can. The longer time you can have that antiviral, on board. Ideally, if I have time, I'd love to see the viral load go to negative. But sometimes, especially in the case of a pretty aggressive cancer, we got to get going with treatment, and we just follow those people really closely. So this was based on a meta-analysis of 12 randomized clinical trials. And the result of that meta-analysis is that prophylaxis reduced the risk of reactivation by 82%. And you can see the tornado plot here is all the studies showed a reduction in risk, and the largest studies had a really solid reduction in risk. There's just one study on the right that had some bias in it, I think the study by Wong, because it was kind of a smaller study. So next, this is an area where things have changed quite a bit. This is kind of that medium area, the people with moderate risk. The 2015 guidelines said, you probably should monitor those people or have a discussion. In this current document, the AGA is saying, let's prophylax these people. Same as assumption around high barrier resistance. And, these are things you need to talk about with your patients, including costs of the antiviral therapy versus monitoring. And then the people with low risk, they said just continue with what we said before. You wanted to just do lab monitoring. And I typically do a 1 month LFT panel plus HBV DNA. If they're going to flare, the first thing that's going to happen is the viral load going up. And I don't really get excited unless it's more than 1 log. So the viral load is your first indicator something's going on. And if that looks good, I usually repeat it at 3 months and then follow every 3 months after that while they're getting their chemo. So then the last recommendation is around screening, and they recommend anyone who's getting really concerning immunosuppressant therapy that they get the 3 tests: surface antigen, core antibody, and surface antibody. And it's reasonable to just start out that you don't have to get a viral load right away. So this is the sheet that I print out and I keep right next to my desk in the liver clinic. And it's helpfully color coded here with green denoted in as low risk, the orange or yellow being moderate risk, and red being high risk. So just remind you, low risk, just monitoring; moderate risk, the AGA is recommending to start prophylaxis; and high risk, definitely start prophylaxis. So pretty much there are very few people who are considered low risk on the far left here. So it's corticosteroid therapy for less than a week or any kind of intra-articular corticosteroid therapy. These moderate risk people are if they have longer duration of steroids or anti-T cell therapy. And then a bunch of folks who are surface antigen positive and getting these different agents, including anti-TNF. So see that quite a bit in rheumatology and also in dermatology, CAR T cell therapy, TACE, Hep C co-infection, or long-term steroid therapy. You want to prophylax those people. So going over to the core antibody positive here on the right, you start seeing more folks falling into that low risk category. So we start seeing Hep C co-infection, anti-TNF, but still a good group of people here in the moderate. And then high risk would be any B cell depleting agent. All right, I'm going to transition to treatment now. And I wanted to start out with this question that I often get asked by my patients. And that is like, why is it so hard to cure Hep B? They've heard about Hep C and like everyone's getting cured. So what's different with Hep B? And so there's a couple of reasons. First of all, there's a lot of surface antigen that's being produced in a person who has chronic Hep B, and that leads to immune exhaustion. It just kind of overwhelms the immune system. And then probably the most important thing is that in the life cycle of Hep B, you have this production of covalently closed circular DNA or cccDNA. It's kind of the way I explain it to my patients is kind of like a hibernating form of hepatitis B. So it's really hard for the immune system and antivirals to penetrate that. And then the last thing that can happen is the HBV DNA can be integrated into the host genome. And this is why we see liver cancer in really young people who don't have underlying cirrhosis. So those are the big reasons why it's so hard. I can't include any talk of Hep B therapy without showing the life cycle and how the cccDNA is a part of that. The targets that we have now are at the transcription level. There is a phase 3 trial with an agent called bulevirtide, which is the entry inhibitor. So it's kind of like T20 or Fusion. I think it's probably going to have as much effect as Fusion does on HIV therapy. I'm kind of pessimistic about it. But then a lot of the targets are downstream here, including siRNAs. But what are some of the pros and cons that I bring up when I'm talking to a patient? The pros are that from a public health standpoint, there's less risk of transmission. So, there's a lower community viral load, and whether that's through maternal child transmission or sexual, that's always important. And then there's a theoretical lower risk of HCC. There hasn't been a randomized clinical trial of this yet, just because it would take decades to do that study. But there are studies from Taiwan in the REVEAL cohort showing that the higher your viral load, the higher your risk for HCC. So kind of makes sense that if you can lower viral load, you will lower the risk of liver cancer. There's a small chance of functional cure. That means surface antigen loss. By and large, these medications have been around for a long time and are pretty well tolerated. And then lastly, I have a lot of patients who just want the peace of mind. So on the cons is really the cost. And I really don't want to minimize this because even though a lot of these medications are generic, they're pretty expensive. They're around $400 to $600 a month, which is, not insignificant. And then I've had a lot of patients kind of go off and on their antivirals without telling me. Sometimes they're traveling out of the country, or sometimes they've had change in the insurance and just don't let us know. And I've seen some really bad flares with people coming off, and it's led to some serious damage to the liver. And then, as you all know, there's some slight risk of renal and bone toxicity with TDF. So I wanted to talk about the guidelines that are out there. The American Association for the Study of Liver Disease, or ASLD, last updated this 7 years ago. They have put out a new guidelines, and they're asking for comments on those. So, it's been a while. We're due for that. A couple of things to highlight here. Anyone with cirrhosis and a detectable viral load you want to treat. And then anyone in the old days, they would say anyone who's immune tolerant. So that means normal ALT, but can have a super high viral load. They said, no, don't treat them. And this is the area where you're going to see probably the most movement. And then patients who have immune active chronic Hep B, they can be both e antigen negative or e antigen positive. They say yes, and it's defined by their ALT and viral load. A couple years ago, there was a group of hepatologists and infectious disease experts said this is really complicated. And for folks who can't access specialists, we need to simplify this. And so they said, again, anyone with cirrhosis, let's treat them. And then they just used a simple viral load cutoff of 2,000 or above, and any kind of elevation in the ALT, 25 or more in females, over 35 in males, and then you should treat. And so that is out there. And I think it's actually on HBV online for folks who want to take a deeper dive. So in Europe, their guidelines came out in 2017, very similar to the 2015 ASLD update. But I wanted to draw your attention to the fourth bullet point here, where they said anyone who's over the age of 30, regardless of the severity of their liver, they should be offered treatment. So that's a little bit different from the ASLD guidelines. And then last year, WHO put out guidelines that are, I think, probably mirror the 2020 guidelines in that they're just trying to make it a little bit simpler and going by viral loads. They use just a cutoff of 19, so a little bit different for women, 30, and men. And the other area was any kind of presence of co-infections. So that would be HIV co-infection, Hep C co-infection, extrahepatic manifestations, or a family history of cirrhosis and liver cancer. They should get treatment. So I was hoping that when I signed up for this talk, I would have the official ASLD guidelines. We'll have to wait for them. We've been waiting for them for like a year. And hopefully the next time I come back, I can give you an update on that. I do want to just leave you with a little bit of a teaser of where we're going in general with Hep B treatment. And this may feel like deja vu all over again for you guys in HIV. So we're going from monotherapy to kind of a triple combo, and it will probably include our nucleoside analogs that we already have, and then these novel antivirals, whether it's an siRNA or a capsid inhibitor. And then the third category is where it gets interesting, is that there's some recognition that we need to have an immune active agent. So whether that's a therapeutic vaccine or a monoclonal antibody, some studies with toll-like receptor agonists, and then interferon. I'm seeing more and more studies with our good old friend interferon coming back. So in general, just wanted to summarize that you should screen patients who are about to start immunosuppressant therapies with surface antigen, core antibody, and surface antibody. And just know that the field is shifting towards a lower threshold for starting treatment, and that the newer therapies are looking better. They're not home runs, they're more like singles. It's going to be more complicated, and we might see our old friend interferon coming back.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.